Hi, everybody, and welcome to the Neurocritical Care Society podcast. This is the Hot Topics series. I am your host, Dr. Rich Choi. I'm a neurointensivist at MedStar Health and social media editor for the Neurocritical Care Journal. Before we begin, please note that the views and opinions expressed in this podcast are solely those of the hosts and guests and do not necessarily reflect the official opinions or positions of the Neurocritical Care Society. Now, joining me today is Dr. Wendy Ziai, and we're going to be discussing the article, The Association Between Hourly Systolic Blood Pressure Variability and Outcomes in Patients with Intracerebral Hemorrhage is Time-Dependent, post-hoc analysis of the ATACH-2 trial that was recently published online in the journal Neurocritical Care. Dr. Ziai, thank you so much for joining us, and welcome to the podcast.
Thanks so much for having me.
Would you like to, I know that you're well known to all of our listeners, but if you wouldn't mind introducing yourself to our listeners?
Sure. So I'm Wendy Ziai. I'm a professor of neurology at critical care medicine at Johns Hopkins, and I am a neurointensivist on faculty there.
Excellent. Thank you so much. Well, without further ado, let's just start talking about this article. So just in terms of background, I know that there's been some increasing impetus recently with regards to not just lowering the blood pressure, but doing so accurately and reducing the amount of variability in cases where you have acute intracerebral hemorrhage. So could you explain to the listeners why you think that this is important?
Sure. So I guess we could start out with saying that blood pressure is important as a risk factor for stroke and particularly intracerebral hemorrhage. And it happens that high blood pressure during the acute phase of ICH predicts poor outcomes, especially during the first 24 hours, but even during the first week, right? And then there are these high associations with hematoma expansion and high blood pressure, and also with neurological deterioration and death. And so, up to now, or up to recently, we've had these two large clinical trials, INTERACT-2 and ATACH-2, and they had fairly different results. INTERACT-2, just to review, compared two blood pressure targets, less than 180 millimeters mercury to less than 140 millimeters mercury systolic blood pressure for the first 24 hours and actually for the first week. And they reported a strong trend to improved outcomes with intensive blood pressure control. And that was, in fact, significant for the ordinal analysis of the modified Rankin scale. The ATACH-2 trial, by comparison, compared a range of blood pressure, 140 to 180, that was the standard care group, to 110 to 139 millimeters mercury systolic, that was the intensive treatment group, and they found no significant difference, actually, in 90-day outcomes. But subsequent trials, INTERACT-3 and INTERACT-4, now have solidified this idea of early blood pressure control, even including the pre-hospital phase. So then we get to this idea of blood pressure variability and whether you have to keep the blood pressure smooth and sustained, especially in the acute phase. And this is an interesting sort of finding. Of course, we expect that the effect of different antihypertensive agents to reduce the risk of poor outcome after ICH probably can't only be explained by the decrease in the blood pressure number itself. Blood pressure variability seems to be an important variable, but the reasons are not fully clear. So there are probably some mechanisms like central sympathetic drive, arterial reflexes and compliance, and levels of substances in the blood like angiotensin 2, bradykinin, endothelin 1, insulin, nitric oxide, etc. And these have been associated or may be associated with things like early hematoma expansion, edema formation, and increased intracranial pressure, which indirectly could drive poor outcomes. But this is like a chicken and egg kind of situation, right? Could it be that the blood pressure variability just is a manifestation of the worsening neurologic injury from the ICH that is actually a result of hematoma expansion and increased intracranial pressure, or is it a cause of those things? And that's what we don't really know yet.
Right, exactly. You bring up excellent points. And thank you so much for that review of the literature. That was great. But with regard specifically to blood pressure variability and that affecting outcomes, other than this piece, are there other pieces of evidence out there that to kind of explore that same question?
Yes, there are a number of studies, a growing number of studies that show significant associations between blood pressure variability which can be measured in a variety of different ways and over multiple time periods up to a week after ICH with poor outcomes. And so going back to the INTERACT-2 trial, there are several post hoc analyses. One in particular showed that the standard deviation of the systolic blood pressure had this significant linear association with death or major disability for both the first 24 hours and the first 7 days after ICH. And they used only 5 blood pressure measurements in the first 24 hours, each 6 hours apart, and 12 blood pressure measurements from days 2 to 7. So a relatively infrequent measurement, low frequency of measurements, and that may have contributed to the results, or it may have even underestimated the results. It's hard to say. There's another analysis of ATACH-2 data using 5 measures of blood pressure variability in, again, systolic blood pressure, and they also found that increased blood pressure variability for all of these measures was associated with worse long-term outcomes in both the acute and the subacute periods. And actually, the effect was even stronger in the subacute period after the first 24 hours. And so if you recall, ATACH-2 only lasted 24 hours, but the INTERACT-2 trial lasted 7 days. ATACH-2 also enrolled patients with blood pressures greater than 180 to begin with, rather than 150, which was actually the enrollment criteria for INTERACT-2. So different enrollment criteria, they used different medications, but they all are sort of showing the same trend that blood pressure variability is important for clinical outcomes. And remember also that these trials excluded people with very severe ICH. So the median ICH volume, for instance, in ATACH-2 was about 10 milliliters. So these were mild to moderate ICH volumes.
Right, absolutely. Thank you. And so this paper is, once again, it's a post hoc analysis of the ATAC-2 trial. You had mentioned one of the other post hoc analyses that was done. How does this add to the body of literature that's growing on this subject? What did the results show?
Yes, so the current study, which again uses the full cohort post hoc secondary analysis of ATAC-2, shows that actually the timing of this increased blood pressure variability, rather than just the magnitude, is again significantly associated with death or disability at 90 days, and also with hematoma expansion and with neurologic deterioration within the first 24 hours. The systolic blood pressure variability was actually examined relative to acute kidney injury, which was an important variable adverse effect in the ATAC-2 trial and was found to not be associated with AKI. And the strongest associations were between outcome and the first 8 hours of this blood pressure variability variable. And if we think about randomization happening about 3 hours after symptom onset, this gives a window of about the first 8 to 12 hours for when blood pressure variability was the most important in terms of its association with all 3 of the outcomes that were looked at.
Right. I thought it was particularly interesting how the INTERACT was the one that did show some benefit, did not involve any acute kidney injury as much as the ATAC-2, which kind of like showed the opposite, but it also had to do with how exceptionally well controlled the blood pressure was in terms of their goals and what they attained. And so what's interesting to me about this paper particularly is how the variability did not really play as much of a role on specifically the acute kidney injury as much as on the other things.
Exactly. And if you look at the blood pressure graphs in those papers, the intensive treatment group had a blood pressure of around 120 to 125-ish, whereas the standard treatment group was in the low 140s. And in the INTERACT-2 trial, those blood pressure measurements were much higher. The trend was in the 140s in the intensive treatment group and around 150-ish in the standard treatment group. So quite a bit higher. And again, reflecting the fact that they didn't see acute kidney injury in INTERACT-2.
Right, absolutely. And so with this new piece of literature coming out that's again supporting this idea that, well, again, it's between the chicken and the egg. It's hard to determine whether this is an effect versus a causation versus just something else that we're seeing. Will this change your practice at all, or what is your current practice?
Yeah, so we, as most centers, treat acute hypertension in the especially first 24 hours after an ICH patient comes in with nicardipine, intravenous nicardipine. Some centers are using intravenous clofidipine, which has a shorter half-life and may allow closer or more precision with blood pressure goals. that time will time will tell whether that is actually the case. But we monitor blood pressure very carefully, obviously in the first 24 hours. But we continue blood pressure goals around 140 to depending on intracranial pressure issues and edema issues. Generally 140 to 160 are our blood pressure goals. And we wean patients off of intravenous nicardipine onto oral agents, generally after the first 24 hours.
And we do something similar at MedStar. We've been using nicardipine primarily. We don't have access to fluvidipine. I did have it in my former position, and you're right. I mean, it's certainly much faster to titrate, but time will tell whether that actually makes a difference or not. There's an interesting trial called the Clutch trial that I'm sure you're aware of, which is going to compare clofidipine and this reduction of blood pressure variability specifically to see if that definitely shows some signal that it's going to change the outcomes and whether or not it's causal as opposed to just an effect.
That's an excellent point to bring up. The data that we have so far, most of these come from these post hoc analyses of the blood pressure trials, and therefore they were not optimized to even look at variability. So we do need data from a large clinical trial where the primary endpoint is actually, or the primary intervention is actually blood pressure variability and not just blood pressure control.
Yeah, agreed. I think that if this data does show some result, I think that that might swing the dial with regards to focusing more on this reduction of the variability and not just the goal overall.
Yeah, I think it is important, especially moving forward with drugs such as clofidipine, to understand that the 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 treatment or the reduction in variability is only as good as the nursing monitoring and the ability to titrate these medications quickly in order to minimize the variability around a specific goal. So in ATACH-2 and even less so perhaps in INTERACT-2, the frequency at which blood pressure medications were changed in the case of ATACH-2, the nicardipine, it was changed, or the blood pressure was monitored every 15 minutes in general, except if there was a change in the dose of the nicardipine, in which case it was monitored every 5 minutes. And so if we really want to chase variability, this is probably going to require more intensive nursing monitoring of drips and of blood pressures, and even may require more arterial lines, right, in these patients where we don't always place arterial lines. I don't know, what's your practice at MedStar? Do you place an A line in every patient with an ICH?
We have not been doing so, but it depends on how easily or not we've been able to manage someone's blood pressure, I would say. What about you?
Exactly. So generally, if we have somebody on a nicardipine drip that is difficult to wean off, we will place an A line, especially for a larger hemorrhage. But if a patient is expected to leave the ICU in maybe 1 or 2 days with a small hemorrhage, say less than 20 mLs, we may not place an A line.
Agreed. Is there anything else that you wanted to bring up about this paper? So maybe perhaps a take-home message for our listeners.
Yeah, I think the main take home is that reducing blood pressure variability in first 8 to 12 hours after ICH onset does appear to impact long-term outcomes, including hematoma expansion and neurologic deterioration, but we still can't say whether the blood pressure variability was the cause or the effect of these endpoints. I think that's the take-home message.
Absolutely. And with that, thank you so much for joining us. Thank you so much for your time, Dr. Ziai. It's been a pleasure as always. And you can all find our podcast available for download wherever you regularly get your pods. Podcasts are also available on the Neurocritical Care Society website, and select episodes are eligible for continuing education credits. Please don't forget to like and subscribe. Thank you.
Thanks so much.